Good morning to all. So my talk is moving from posterior segment to anterior segment once again. And some points have been covered in the morning session regarding keratometry, immersion biometry, IOL power calculation. But my talk will be mainly utilizing on the online formulas which are available. And sometimes they are of very help us to reach at the final IOL power. Now, before we go on to any machine to put in the data, these are some of the very important points which we need to collect before we put in those values. One is the keratometry. Of course, we know keratometry is very, very important. We use either SIM-K or a total keratometry depending on the case. Like if we have a post-LASIK case, sometimes we need a total keratometry for those patients. Then pachymetry, thickness of the cornea, axial length of the eye is very, very important, anterior chamber depth, lens thickness. And nowadays there is a more stress on the effective lens position, which is called a ELP. So ELP nowadays, there are many parameters which help us to go for the exact ELP. Then Y to Y diameter and pre-operative refraction if it is available. Some of the formulas use pre-operative refraction also as an input so that we are able to reach to a nice power of the lens. Now while calculating all these values, we should keep in mind that even a very small error in the keratometry and the axial length can give us very false readings. Like keratometry, 1 diopter error can induce about 0.9 diopters of error in the IOL formula. Then axial length 1 millimeter error can lead to about 2.5 diopters. Again, depends on the axial length. It can vary from 2 to 3 diopters. Smaller the axial length, more is the error. Then axial length and ELP measurements, if we look at all the formulas, these are the main source of error. So we have to have maximum accuracy in the axial length and ELP measurements. We'll not go into details about keratometry because I hope in the morning session has been discussed. So one can see that we can measure keratometry in diopters as well as millimeters. And cornea we know is a major source of refraction, about covering 75% of the refraction. And always we get two readings if it's a regular astigmatism, K1 and K2 values. So most of the keratometers, whether it's optical based or manual keratometers, they are giving us the SIM-K, means simulated keratometry values, and they are not calculating the posterior corneal values. So these are some of the parameters for the cornea which we see, that we have to look at the anterior surface which covers a good tear film. So if the tear film is not good, sometimes we may not be able to get the accurate keratometry. So patients sometimes, if they have dry eye, we need to treat them for a few days and then only to have the proper keratometry. Well, again we have the manual as well as the optical ones which give us the accuracy about the keratometry values. The calculation of the axial length, we all know we use either ultrasound or use the optical methods, which are mainly decided on basis on the PCI, partial coherence interferometry, or swept source. Now the ultrasound based is mostly out these days. The reason is that optical biometers are readily available, but there may be some of the situations where still we need to do ultrasonography. And in those cases, it is better not to use contact biometry, because contact biometry gives some error, it puts pressure on the cornea, and you get a shorter axial length and a more higher power of the lens. So always better, if you are doing it to use ultrasound, then better to use a immersion type of biometry, because error in this is about 0.12 millimeters, which is not sufficient. So we use a Prager shell. This is the Prager shell which is put on the cornea, and balance salt is injected and a probe is kept there. So it gives us a very good accuracy of the axial length of the eye. Now, because we know almost everybody has the optical biometers, this we know is a non-contact methods, and it calculates the axial length from the cornea to the retinal pigment epithelium layer. Uses the principle of either interferometry or swept source. So the accuracy compared to the immersion is about 0.02 millimeters. It means the optical biometers give us more accuracy towards the axial length. So these are some of the biometers which are available. We know one is from TOMI, another one is from IOL Master. So these are what give very accurate readings. And sometimes we need the help of the Pentacam or a Cirrus Plus which is a corneal topographer, if we have a patient of keratoconus or if we have a patient of post-LASIK, then the total keratometry value may be required. So total keratometry value we can only get from the pentacam or from the Cirrus type of tomographers, which give us the accuracy of the corneal. Then effective lens position can be calculated by the optical biometers, and this photograph shows us that this is the lens position, which is based on the anterior chamber depth and the lens thickness. So if we have the two parameters accurate as well as wide to wide, then we get more accuracy in the ELP, that is effective lens position. Now this is how the ELP calculation has been done over the years. So nowadays we are using the preoperative anterior chamber depth and the lens thickness. So they provide us more accurate the ELP. So we can see in this photograph here that this is the position of the lens, where the lens is going to rest after the surgery. So this is a pseudophakic eye. So where we have to estimate, because little bit movement of the lens, either anterior or posterior, can give us inaccuracies in the calculation of the IOL power. So that is why I said the ELP has become very, very important for calculation of the accuracy in the IOL power. And another parameter which is considered for using the online biometers is a wide to wide. So this either can be calculated manually, or the optical biometers or even the pentacam provide us wide to wide. So wide to wide again has become a very important parameter which needs to be put in some of the formulas to reach at the more accuracy of the ELP and the final IOL power. These optical biometers, they have some of their own limitations, like sometimes the rays don't penetrate the dense media. If we have a posterior subcapsular cataract, dense vitreous hemorrhage, presence of retinal detachment and nystagmus. So patient need to have a good stable eye if we can calculate, use the optical biometers. Or if the patient has dry eye, so these patients need management of dry eye before we really calculate the IOL power. Now number of formulas are available which can be used to calculate the IOL power. I will not go into details. So these are some of the formulas which were used earlier to calculate and to give us some clue depending upon the axial length. Like if we have a long axial length, then Holloway 1, Hofer Q, and nowadays we have the Barrett Universal 2, which gives us the accuracy in the more accuracy towards the IOL power. Now this is what mainly I want to cover, online formulas. Sometimes what happens that the biometers may not have all the formulas. Usually we get about 4 to 5 or 6 formulas in any optical biometer. But still we had doubt that whether the power which has been given by this is accurate or not. So then we have online formulas like Hill RBF version 3 is available. Barrett Universal 2 is mostly incorporated in the optical biometers. But if it is not available, one can use it online. And then CATE formula, EVO formula, ASCRS formula and ESCRS formulas. So I'll discuss each formula a little bit in detail. So this is what Hill RBF formula is available. After we put in all the patient data details of the doctor, then we put in all the parameters here. So we can see all the parameters like the axial length, the corneal thickness, the axial length, and all the keratometry values wide to wide. So as I said, wide to wide has become very, very important. So then ultimately, once we do the calculation, then it tells us the IOL power. So this Hill RBF is based on the artificial intelligence also. So the accuracy by using this formula is to the tune of about 90%. 90% of the cases will be falling within 0.5 diopters. Then Barrett Universal 2, most of you might have used. It's already available in most of the biometers. So if it is not available and still you want to reconfirm the values, then again put in all the parameters and then you get the IOL power. Same way, toric calculation, if you are implanting a toric lens, the toric IOL calculator is available, so which will tell you the power as well as the axis of the placement, depending upon the astigmatism. But here when you use a toric calculator, it is important to know the SIA, that is a surgically induced astigmatism. So every surgeon should know how much is their surgical induced astigmatism. So you have to input this data and then only it tells you and where is going to be the location of your incision. Because some people want to operate at 180 degree or some upper temporal or superior. So depending upon that, you may be having alteration in your SIA. So knowing the proper SIA is very important when we calculate the toric. The axis as well as the power of the lens is very important. Then it will tell you how much residual error is going to be there once you have the toric lens implanted. Similarly, we have a Kane formula. So this again can be used for normal eyes as well as patients of keratoconus or same formula we use for the toricity also. So this formula itself provides the toric IOL calculation also. So you have calculation for the normal eye with a less astigmatism, you have calculation for the eye having high astigmatism, where you are planning to do a toric IOL. So this single formula can give us all the proper readings. ASCRS, we know, again this is available online. This formula is mainly used for patient of post LASIK surgery. So you need to put in whether patient has undergone LASIK for hypermetropia or for myopia, or even patient has undergone radial keratotomy in the past. So all the three, if we do that, which type of lens we are going to calculate, then it needs little bit more input in the form of topography parameters, in the axial length and all. So ultimately, when we calculate, it will tell us the power which we need to put in a, because source of error in a post LASIK eye is the change in the corneal mechanics. Because normally when we are calculating the sim k, the value of sim k is based on the Gould-Strand ratio, so which tells us the average value of the cornea. But this gets altered in a post LASIK patient. So then we need to either to know the posterior corneal astigmatism, and then we have to have a true K value. So if we have the true K value, that is the one which is going to give us more accuracy towards the patients who have undergone LASIK surgery. Now coming to this last formula, this is the ESCRS formula. The advantage of this formula is that we are getting Barrett in this, we are getting K6 formula, we are getting EVO, Hill RBF, Hofer Q, Kane and Pearl DGS. So it means in a single calculator, you are getting all the formulas. So no need to go into individually like Hill RBF or go into a Barrett or EVO. This single calculator will give us all the parameters. So you put in the parameters, it will give us the values for all the formulas. Then based on your experience, you can choose the power of the lens. Like here, if you put in all the parameters, starting from the axial length and all, you fill in all the parameters. Another advantage of this formula is that you need not to put the A constant, because A constant here I will show you is already available in this calculator. You just need to see which company you are putting the lens and which model you are putting. So automatically it will give us the A constant of that, and also will give us the power. Now here, when you are calculating, just this is a menu here, which when you go down, it tells us all the lenses. So majority of the lenses, even the Indian lenses like Orolab and Appaswamy lenses are available in this formula. So you need to see which lens you are implanting from which company. So choose that, and then it tells us the power. Like here you can see when you do all this, then the power of the lens comes here. So you can choose the power based on your experience, whether you need, like here you need this, the upper one or the lower one. So all the 7 formulas are giving you the power in one go. So you have all the 7 formulas, and then you can just put in the lens based on your experience, whether in the previous, like if you are getting little more myopic, you can go for little more hypermetropia, or if it is hypermetropia, you can go little bit more towards the myopia. The keratorefractive surgery, we know it's a special situation. As I discussed, for such patients, you need to have either ASCRS formula, or you need to have a true K value. So true K value usually comes from the Pentacam or from the Cirrus Plus, or a Holaday report. Like this gives us the anterior as well as the posterior corneal values. So when you have the posterior corneal values available, then you can put in those values, and this will tell us the exact IOL power which we need to implant in a post-LASIK eye. Nowadays we talk of artificial intelligence also. We know many formulas have artificial intelligence based calculations. It means that if you already have the experience using a Hill RBF formula and you have put in all the values, that you put this power in this patient and this is the residual error for this patient. So based on that, your past experience, the lot of values have been input into the artificial intelligence, and this has been incorporated into many formulas, and ultimately you get more accuracy towards the IOL power. This is a LADAS 2 formula also, which uses artificial intelligence and gives us more accuracy towards the powers. So conclude, proper IOL power calculation has become very important to target emmetropia, And these days you might have seen patients coming, doctor, I can't see clearly. Even if when you check their vision, it's a 6/9 vision, but still they are not happy. So why they are not happy? Because they might be having some refractive error. Cornea is clear, anterior chamber is no reaction, the lens is in proper position, but still post-operative you are getting a vision of 6/12, 6/9. But patient says I am not able to see clearly. So that part also becomes very important so that you can give them maximum accuracy towards the IOL power. So the calculation of lens power has become very, very important these days. And in case the optical biometer is not available, and if you have to use the ultrasound, then it is better to use an immersion method because that gives more accuracy towards the axial length. Among the optical biometers, many biometers are available in the market. Nowadays, there is a more tendency towards the swept source based OCTs because they give us more penetration of the light, and even patient with the posterior subcapsular cataract or little bit dense cataract where the light can go in, you will get the values for the IOL. The customization of the IOL power. You are using the formulas, you are doing all the calculation, but still you are getting some refractive errors, post-cataract surgery. So then there may be need to customize your own A constant. The A constant is provided by the company, by the lenses. Each lens has its own A constant. So if you are repeatedly getting some kind of error, then you can manipulate or customize your own IOL A constant for that particular lens. So either you can, like if it is 118.4, you can make it 1.83 or 5 depending upon your post-operative results. Among the latest formulas, ESCRS online calculator has given multiple formulas and choice of the multiple lenses. So that is the advantage that you don't have to remember the A constant of each and every lens. So each and every lens is available in this formula. Mostly nowadays I am using this. After the optical biometer, I put in my data into this and then try to see that more accuracy if I am getting towards the lens power. So thank you very much.